Good morning, everyone. Welcome to Grand Rounds. Peter's asked me to say a few words at the top of the meeting. We are, as you know, we've been working with Peter and with Kelsey and the team to try to enhance our Grand Rounds platform, as well as our global impact. And what better way to do this with our guest speaker today that Peter will introduce shortly. The steps that have been taken are to improve the platform, and now we are providing this into a global audience. We have guests from all over North America, 120 and counting already. This is thanks to the work of Peter and his team, but also with the help of our communications team with Andre and our new hire, Bonnie Chen, who will be helping us to promote the rounds more and better. I must say I visited Mass General virtually in the past year, and they certainly have it right in how they do it. And we'll be hearing from Jim shortly, and his experience, obviously in biomarkers and heart failure, will be educational. But in terms of learning how we can improve our global footprint, we look forward to enhancing this as we go forward, and as we potentially and hopefully move towards a more hybrid approach as well in the near future. With that, I'll pass it now to Peter to introduce our guest speaker.
Yeah, so thanks so much, Rob, and welcome everybody, bienvenue, bonjour, and à cette conférence. And so today is really a red letter day, I think, in our series of Grand Rounds. But before I introduce our esteemed speaker, just a few logistic reminders. So if you have questions, please feel free to post them in the Q&A feature. You can do this just along with the lecture, and we'll endeavor to answer them at the end of Dr. Januzzi's presentation. And we can also accept live questions as well. And so please use the handout feature, and we can invite you to join the panel discussion. And if you have any technical features, please use the chat feature, and then Kelsey or Allison will be able to help you to make sure you can join successfully. And so it's really a fantastic day today, and we were just sort of mentioning earlier in terms of the fact that Jim was a esteemed invitee, I think maybe 4 or 5 years ago, and he was such a big hit that we always want to invite him back. And of course, hard to do it in person, so we'll do it, in a hybrid fashion today. And this is really a special honor to welcome as an icon in cardiovascular medicine and also cardiovascular research, and continue to provide the inspirational collaboration for us. Dr. Jim Januzzi is the Hutter Family Professor of Medicine at Harvard Medical School and senior cardiologist at the Mass General Hospital, and also cardiometabolic faculty at the Bain Institute for Clinical Research. And he is a world-renowned clinician, teacher, and clinical trialist. His research focused on the understanding of cardiac biomarker testing as it pertains to diagnosis, prognosis, therapeutic interventions in multiple forms of heart disease, including, for example, heart failure, acute myocardial infarction, and others. And this is very much a central tenet of our ongoing research priority here at the Heart Institute as well, and the region in terms of precision medicine in cardiovascular disease. And his work was establishing the emerging biomarkers that really set the international standards for their clinical use today and the application in clinical trials. And we are really fortunate to actually benefit from Jim's insightful collaboration on our institute's own biomarker programs, and we are so grateful. And he continues to challenge us, but also open new vistas in research on an ongoing basis. Dr. Januzzi also has deep experience in clinical trial design and execution. He's been involved in numerous pivotal multi-center trials, evaluating medications, devices, and is currently involved in the study of therapeutic avenues for heart failure, diabetes, kidney disease, and others. He's published more than 700 manuscripts and works been cited over 100,000 times, H-index 122, my goodness, and is associate editor at JCC, as well as JACC Heart Failure, and serves on the editorial board of many prestigious scientific journals. And currently now, I'm also learned to be on Twitter, and I realized that Dr. Januzzi has a huge following on Twitter, educating many others around the world on the tips of heart failure care biomarker, and also tips on medicine in general and the life. And also, I think it's very important to know that not only he's currently a trustee of the American College of Cardiology, but most importantly, he's the team physician for the Boston Red Sox since 2005. So it's absolutely our pleasure to have Dr. Jim Januzzi today for this Red Letter Day in our Grand Rounds, and he will be discussing evolving standards in the medical care of heart failure. Thank you so much, Jim.
Yeah, thank you, Peter, and my gosh, thank you for that really, really kind introduction. I'm honored to come back. You know, in fact, Peter, it was 6.5 years ago when I was last there. It was in 2015. When I came up, it was a very special visit. I had the opportunity to spend time with you, your staff. I met Professor DeBold, who is my career hero. In fact, a nice funny story about you know, meeting him. We were at dinner together, if you remember, and they were very careful to seat me next to him. And you know, I mean, it's kind of hard when you're sitting next to your hero. I mean, I just wanted to chat with him and talk, and I kept bringing up work and talking, and he looked at me and he said, "Do you want to go to the bar?" And I'll never forget that. It was such a moment of just simple humanity that, you know, for me, you know, that really, I think, sort of sets the exemplary sort of, you know, expectation for someone like Professor DeBold, someone like you, Peter, somebody that I try to model myself after, you know, which is to try to support our trainees and support the people who follow, because really in the end, you know, it's our legacy. And, you know, I was so saddened to see Professor DeBold's passing. It really affected me greatly. And I'm glad to be back to speak with you all today about a subject that, you know, brings our worlds together, which is, you know, I am in fact a clinician. I also happen to be a translational researcher. And there's no better example of how those two worlds have come together in a big way in the last few years with respect to the evolving standards for the medical care of heart failure. So there's something for everyone here, you know, something for the translational researchers, something for clinicians, something for patients, important lessons that we've learned. As Peter said, I do work at the BAME Institute, and we do industry-sponsored research, so it's important to emphasize that fact, you know, before we start. What I'd like to do today is first, you know, briefly, I don't think we need this, you know, all that much, but to define the problem in heart failure. But I want to reframe how we might think about this problem. We all know there's a lot of heart failure out there, but it's how do we close the gaps in the care for these patients, identifying guideline-directed medical therapy. You're going to see the GDMT abbreviation all the time. Peter mentioned Twitter. There's a hashtag GDMT works, which I use all the time. And you'll see why, because I think it's important for us to keep that as a core message. There's some exciting data now with respect to heart failure with preserved ejection fraction. In fact, the US Food and Drug Administration just approved empagliflozin 2 days ago for the care of patients with preserved EF heart failure. And then we'll talk about the unfortunate existence of treatment gaps in heart failure. And so, as I said, I'm not going to spend any more time than this in terms of framing the problem that we deal with in chronic heart failure, which is that this rubric that Mihai Georgiadi created many years ago, but really holds well in 2022, really spells it out for us, which is that a compensated patient with heart failure eventually starts showing a decline in their clinical status marked by these periodic, sometimes catastrophic dips in their clinical status, marked by congestion, followed by myocardial injury, which then leads to subsequent progression of these very increasingly frequent phenomena. So when I talk about the problem in heart failure, it's not this, it's not these events. Yes, that's a problem. But the bigger problem is the fact that we allow our patients to slide down the hill to get to that place. And it's closing the gaps in the guideline-directed medical therapy that we know reduces progression of heart failure. I mean, it's been shown repeatedly in different studies is really critically important. And the challenge here is not identification of optimal therapies. The challenge is actually the fact that there are glaring inconsistencies in the application of these therapies in eligible patients. And so let's talk about reduced EF heart failure first. These are data from the CHAMP-HF registry. From North America. These are North American practices. And there's an important take home from this that people often don't realize when they see these grim statistics with respect to, just how awful the application of GDMT was in CHAMP. The key with the CHAMP registry is the reality that we deal with every single day, which is if you look in a heart failure practice, or in Canada, I think you call it the heart success practices, right? Or heart function clinics, the adherence is actually rather good. But the problem is the vast majority of patients with low EF heart failure, even in a transplant-focused world like us in the United States, is still in the hands of general cardiologists and even primary care physicians. And so penetrating that world with the knowledge of how important optimal therapy is a major challenge. And indeed, we have newer therapies that have been shown to be better than I wouldn't say older therapies, but more traditional therapies. The classic example, of course, has been the emergence of sacubitril valsartan, previously known as LCZ696. This is an angiotensin receptor neprilysin inhibitor. It's a combination of a drug that blocks angiotensin 2, so it blocks the bad. We know that is one way to reduce risk in heart failure, but through its effects to inhibit neprilysin, we see a pharmacologic increase in a number of vasoactive peptides, and we'll talk about what those may be in just a little bit, that exert benefit in heart failure. So it's a combination of blocking the bad and raising the good. And in doing so, you can appreciate, for example, in the Paradigm HF trial, now published 8 years ago, that treatment with sacubitril valsartan was associated with a 20% reduction in the primary endpoint of cardiovascular death and heart failure hospitalization. Now, what's interesting is that despite this fact, uptake of the drug, cost notwithstanding, uptake of the drug has been very slow in recent studies. Only about 20 to 30% of eligible patients have been changed onto sacubitril valsartan. And that's really curious. And one of the things that has come out from the market research that we have done at the American College of Cardiology and in other places is that there's a lot of uncertainty about the mechanisms of how and why this drug could possibly reduce risk the way it does. So we started to think about this from a research perspective a few years ago, because the goal here as a clinician is to try to clarify why this drug is important to patients, why this drug is important to clinicians, in order to better understand, how we might improve adherence to what we know as best care. One of the things that we started to think about, probably, a while ago, maybe about 7-8 years ago, is the fact that sacubitril valsartan in the Paradigm trial not only reduced the risk for pump failure death, which you would expect from an inhibitor of the RAS and a vasodilator, but it also had a similar reduction in sudden death associated with its use. Furthermore, use of sacubitril valsartan reduced sudden death regardless of the presence or absence of a cardioverter defibrillator. And the impact was particularly noteworthy in those with non-ischemic cardiomyopathies. So you take a step back and, someone like myself who sees a lot of heart failure patients, when I see results like that, I immediately say, aha, this is an effect on myocardial remodeling, right? Non-ischemic patients in particular are they who were most likely to show what we refer to as reverse remodeling after heart failure treatment. So we hypothesized that this was an exaggerated, more so than enalapril, an exaggerated response with respect to cardiac remodeling. So for those that don't know what remodeling is, I often make this quip that remodeling is good when you do it to your house. It's not good when you do it to your heart, right? So remodeling is a bad thing. It's defined as a change in the size, shape, and performance of the heart muscle. And there's a huge number of molecular mechanisms that Peter Liu could talk about that, explain cardiac remodeling. But suffice to say, it's marked by inflammation, reduction in contractile force, ultimately apoptosis and necrosis, and fibrotic replacement of myocardium. And what eventually occurs, although initially adaptive, it becomes dysfunctional, leading to a dilation, a change in conformation of the myocardium. The heart takes on a more spherical shape, and a reduction in ejection fraction. And this reduction can affect not just the left ventricle, but actually all 4 cardiac chambers. Now, this is where the translational part of the story comes into play, which is the fact that many of you know, for many, many years, I've worked with cardiac biomarkers. I had the fortune to collaborate with Gordon Moe and with Peter and with many others looking at numerous biomarkers, but one of them, of course, is natriuretic peptides. And it turns out that, and just for the interest of time, I took a bunch of mechanistic slides out, but we often think of NT-proBNP as a congestion biomarker because we measure it in the hospital in symptomatic patients. But the mistake that we've been making over the years is that NT-proBNP in decongested, stable ambulatory heart failure patients is more determined by wall stress, which is more determined by remodeling status and less by congestion, right? So the question that we hypothesized was, can concentrations in a non-congested ambulatory patient tell us about remodeling status? And so we did some studies early on within our group. You can see Annabelle Chen-Tournou from Montreal is here as well. She was part of our group at the time and still works with us periodically. And we were able to show that in a population of around 150 ambulatory patients with reduced ejection fraction, that a lower NT-proBNP after 1 year of guideline-directed medical therapy was associated with reverse remodeling. In other words, a lowering of index volumes and a raising of ejection fraction. Furthermore, from this clinical study, it was a clinical trial, we identified a cutoff of around 1,000 for NT-proBNP associated with improvements in clinical outcomes. Now, I failed to mention that improvement in remodeling parameters is strongly associated with improvements in outcome, right? And so when we see this cutoff of 1,000 being associated with better outcomes, we began to wonder if that was a signpost in the road identifying a threshold for reverse cardiac remodeling. And indeed, in the Guided HF trial, which was a neutral study overall, we were able to show that those individuals that reached an NT-proBNP just slightly over 1,000, the slope of reverse remodeling began to accelerate, such that when you look at paired echocardiograms at baseline and end of study, the NT-proBNP achieved at 1 year was actually quite predictive of whether patients were on the uphill improvement or still sitting somewhere in an area where you don't want them to be, where their EF isn't improving or actually worsening. So that really caught our eye and made us sort of think that there was something to this, because simultaneously in the paradigm study, and now we jump back to sacubitril valsartan, the investigators showed that the outcomes in the paradigm trial, regardless of whether you were treated with enalapril or sacubitril valsartan, were largely determined by the 30-day achieved NT-proBNP. Stated another way, it didn't matter if you were on sacubitril valsartan or enalapril. If you got a really low NT-proBNP after randomization for whatever reason, you are very unlikely to have a clinical event, right? And it just so happens, however, that we recognize that treatment with sacubitril valsartan is like napalm for lowering NT-proBNP values. So people in the trial were more likely to achieve an NT-proBNP less than 1,000 if they were on sacubitril valsartan. Long story leading to a study that we did called the PROVE-HF study. In PROVE-HF, our goal was to understand this really interesting and well recognized by now effect of sacubitril valsartan to cause a dive in NT-proBNP values when the drug is started in people with reduced EF heart failure, and really try to understand if we can link up this behavior of NT-proBNP with subsequent mechanistic endpoints, including cardiac remodeling. So what we were able to show in this study is that even within the first 2 weeks, at a time when folks were only taking dose level 1, the lowest dose, 24, 26, twice a day, the majority of NT-proBNP reduction occurred during that very early time point. By 2 weeks, there was a 30% reduction in NT-proBNP. Now, this early reduction in NT-proBNP was strongly predictive of reverse cardiac remodeling. And I should mention that the majority, more than 80% of the study participants were taking an ACE inhibitor or ARB and were switched to sacubitril valsartan at the time of study entry. Those early reductions in NT-proBNP were strongly predictive of the stepwise rise in ejection fraction from baseline, 6 and 12 months in these 800 patients with reduced EF heart failure. How much improvement? Well, the upper quartile of individuals had an EF increase, an absolute EF increase of 13% or more by 12 months. And we're going to talk about the clinical ramifications of that in a second. Of course, when EF improves, you also see reductions in left ventricular volume. So this is the hallmark of reverse cardiac remodeling, right? A reduction in LV volumes. In addition, there was reduction in left atrial volume index, improvement in diastolic function as assessed by E over E prime, and a reduction in left ventricular mass index. So those 5 metrics all pointed towards a reverse cardiac remodeling impact of sacubitril valsartan. These effects were extended to individuals who actually were not included in the Paradigm HF trial. So at the time that we did PROVE-HF, we realized that because Paradigm ignored people who had new onset heart failure who had not received an ACE inhibitor or ARB, or those with relatively lower NT-proBNP values, or those not reaching the target dose. Remember, in Paradigm, you may not know this, but if a person couldn't get to the highest dose of sacubitril valsartan, they were bounced out of the Paradigm trial. So we looked at each of these subgroups, and you can look at the various metrics, but the EF changes were pretty similar in all of these underrepresented groups in the Paradigm trial. And notably, new onset heart failure, very well recognized to be most treatment responsive, had the largest EF increases. And we have an analysis coming soon about to be submitted for publication looking at this phenomenon. And indeed, new onset heart failure, and I'll swing back to the clinical world in a second, is an ideal place to think about getting your optimal care on as soon as possible, as we'll discuss. Now, mechanistic insights. How did the drug reduce cardiac remodeling and foster reverse remodeling? Well, if we hold that NT-proBNP reflects wall stress and remodeling parameters in chronic heart failure, and wall stress, as I mentioned, and remodeling is associated with cell death, other biomarkers such as high sensitivity troponin might actually be able to inform some of the mechanisms of benefit of sacubitril valsartan. This is a curious figure and I love it so much. It's a complicated one though, and I'll walk you through it. On the x-axis, you have troponin T, so high sensitivity troponin. On the y-axis, you have NT-proBNP, and on the z-axis, you have ejection fraction. those individuals with the largest reductions in both NT-proBNP and troponin, as manifested up here in these darker green circles, were the ones who had the highest improvement in ejection fraction. And what was really interesting in this study wasn't this finding. You know, we see lots of multi-marker stuff in the literature, and that doesn't inform much from a clinical perspective, but we had sort of one of those eureka moments when we looked at something, because in PROVE-HF we drew blood 10 times over a year. We were able to look at the sequential changes in NT-proBNP and troponin. And often in these analyses, the investigators measure the markers at the same time point and panel them together that way. What we actually found was that time zero NT-proBNP change was more predictive of time 0+1 troponin change. In other words, reduction in wall stress preceded the reduction in high sensitivity troponin. And that's the first time that's actually been shown, and really starts to tell a story about how we might use troponins in a non-acute setting to understand the presence of wall stress, to understand the injury that occurs in that setting, and its improvement, of course. In subsequent sub-studies from PROVE-HF, we were able to also examine important groups of patients that are often neglected in clinical trials, including women. We had a large percentage of women and versus men in PROVE-HF, showing, in fact, that women actually had slightly higher EFs at baseline, but reverse remodeled faster than men. So, you know, anything a man can do, a woman can do better, it seems, and this is another example of that. In addition, this was a North American study, so we were able to also look at relevant racial and ethnic subgroups. And as well, we see similar reverse remodeling effects, but with different velocities and with different starting and ending values. So important observations in terms of the broad-based applicability to patients that were not represented well in the paradigm trial. Now, we get back to the clinical question of cardiac remodeling and its ramifications. These data to me are one of the more important findings from paradigm as well as from PROVE-HF, which is if you hold that a drug can reduce sudden death, and we link that reduction in sudden death with reverse remodeling, and we think about both sudden death and prevention of sudden death based on an ejection fraction standard, largely, which is to say an ejection fraction less than 35% with reduced EF heart failure. And there's this big treatment gap of people not receiving the drug. A question that needs to be asked is, should a patient be optimized on ARNI before deciding on whether or not they should get a primary prevention ICD? So we looked at this question in PROVE-HF. And so seen here are the shift, is the shift in ejection fraction from baseline to 6 months in the left panel, baseline to 12 months in the right panel. So a shift to the right means the EF is getting better. So you can see the general histogram for all the study participants would indicate that very, very few people who started with an EF at 35 or less worsened. Most people actually improved pretty substantially. So what does this mean in this population of individuals eligible for an ICD the moment they joined the study? Well, what we found was that by 6 months, 32%, so 1 in 3 individuals who are eligible for a primary prevention ICD, by 6 months were no longer at or below 35%. And that number by 1 year had risen to 61%. Now, people might say, okay, wait a minute. I am not going to sit back and let my patient who's at risk for sudden death wait for their EF to get better because, you know, they might drop dead. How many patients in this analysis had a sudden death? And the answer was 0, not 1. So in the course of excellent heart failure management, the risks for the acute event are mitigated to a large degree while the EF is improving. And so, you know, how do we put this all together? I would say clearly for those individuals who have the obvious high risk for sudden death, very low EF, ischemic patients, people with a heavy burden of arrhythmia already evident, it's a no-brainer. On the other hand, particularly for those individuals who are at a highest likelihood for reverse remodeling, where the impact of these therapies would be expected to have a substantial benefit, new onset heart failure, non-ischemic heart failure, those patients should be given all chances to improve before thinking about device placement. And of course, this goes hand in hand in a way with the message learned from the Danish trial, which is that the benefits of ICDs were less obvious in non-ischemic individuals receiving optimal GDMT. So it begins to reframe the sort of monosynaptic reflex arc of EF35, put a box in, and really, again, puts the importance of, GDMT works hashtag right up front, in terms of the optimal care for our patients. Now we swing from clinical back to translational, which is, a study like PROVE-HF, and we were talking, Peter and Rob and I were talking before about how, studies like PROVE-HF provide the opportunity through biorepository construction to ask important clinical and biological questions, translational questions. And one of the things that we wanted to examine was understanding how neprilysin inhibition really leads to benefit. Stated another way, we know that blocking neprilysin causes a rise in all sorts of vasoactive peptides, some good, some bad, right? And so the question is, which of these is leading to the effects that we see with the drug, with a really substantial rise in cyclic GMP, which implies stimulation of the natriuretic peptide receptor as being one of the major means by which the drug causes the good things that it causes. But the problem with this is that the only cyclic GMP stimulator that had been studied to date was B-type natriuretic peptide. And, quote, everybody knows that when you treat somebody with sacubitril valsartan, there's some increase in BNP. We just published about a couple of weeks ago that increase is actually not that much. It doesn't drop the way NT-proBNP does, but the small changes in BNP just don't seem to explain the benefit at all, in fact. So I'll draw your attention to this hierarchy with respect to the affinity for neprilysin. This is a metalloproteinase. It's ubiquitous. It's found everywhere, but in the kidneys in particular. And among the most avid or high affinity targets for neprilysin is ANP. So ANP, I don't need to lecture you all about the importance of ANP, and it breaks my heart that I cannot show the next slide to Dr. DeBold, because again, he was the person who got me interested in this area to start. And what we found, and he did, in fact, after our paper was published, make a comment about it, was that we were able to show that there was a massive rise in ANP among individuals in PROVE-HF that were treated with sacubitril valsartan. So we saw a 0% increase in BNP by 12 weeks, 0%. In other words, it didn't rise. There was a 200% increase in ANP by that same time point. And that early substantial rise in ANP most strongly correlated with cyclic GMP change. And it's a challenging analysis because certainly sicker patients started out with high ANP values, but it's that early rise that was the most predictive of the later gains in ejection fraction and reduction in atrial volume. In other words, ANP is the body's way of bailing people out with chronic heart failure. So you expect them to be elevated in sicker hearts, but in those individuals who got an even bigger boost in ANP from starting on sacubitril valsartan were the ones who had the biggest amount of reverse cardiac remodeling. So this brings it all the way back home to the earliest observations that Adolfo made in his work in Montreal and subsequently in Ottawa, really showing how ANP may very well be a really critical pharmacologic agent for the management of chronic heart failure. So I've swung back and forth, much as my life has does, between translational and clinical. I'm a clinician, I'm a researcher. But most importantly, at the end of the day, what matters to me most is how my patients do. And at the American College of Cardiology, we're greatly focused on optimizing medical care for heart failure, and recently published a consensus document. The guidelines are coming out in about 4 weeks, actually, from the ACC, AHA, and HFSA. But our consensus document addressed optimal medical management of individuals with reduced EF heart failure. And we talk about this idea of ARNI first. And this was the first time that a policy document from any society. The Canadian Heart Failure Society followed not long after, actually, to your great credit, with saying, you know what, enough of this silliness about, you know, a patient must be stable on an ACE or an ARB before going to an angiotensin receptor neprilysin inhibitor. Why? Well, why do we say this? Number one, there's no biological plausibility. I mean, quite frankly, it's ridiculous to think there's any reason why biologically it should affect the subsequent course if a person hasn't been on an ACE or an ARB. I mean, there's an ARB in sacubitril valsartan, for gosh sakes. Second of all, going direct to ARNI is actually quite well tolerated. People argue that maybe starting somebody on an ACE or an ARB first would unmask a propensity towards angioedema, you know, a not common but concerning side effect of sacubitril valsartan. Not so. Also, hypotension is not predicted by response to ACE or ARB, so that doesn't make any sense. Importantly, and perhaps most worrisome to us, is that when you look at the benefits of this drug and the next one I'm going to talk about, they show up within 30 days of being started. And so if you sequence a patient, start them on an inferior therapy, you're not only waiting for them to fail that therapy by giving them a chance to not be accrue the benefits of sacubitril valsartan. I mean, that isn't that, as I opened my talk up with, exactly what we're trying to prevent, to keep our patients on the smooth course rather than those periodic dips. And the benefit appears so early. For example, in Paradigm HF, you're not giving the patient the optimal care they deserve. Ultimately, it comes down, I think, to you know, clinical inertia and the ability to rapid sequence add the therapies that we know are beneficial. ARNI is one, and of course, Sglt2 inhibitors, our next new kid on the block, is another. So, as Peter said, I've been very, very fortunate in the ability to play in a few different sandboxes, so to speak. And, you know, sacubitril valsartan was one, and now Sglt2 inhibitors was another. Complete dumb luck. We were talking about this before the talk started, you know, and yes, you know, you can sometimes make your luck, but sometimes luck just falls in your lap. And I was fortunate enough, just by pure happenstance, to be involved with the EMPA-REG outcome study, which was the first SGLT2 inhibitor study to come out showing a benefit of SGLT2 blocking the sodium glucose cotransporter 2 in the proximal tubule. This is a drug that causes modest glucose lowering, but that wasn't the really interesting finding, as you all know from EMPA-REG. These drugs have a number of different biological effects. They cause a diuretic and natriuretic effect. They have a mild effect on lowering blood pressure. Through glucose wasting and diabetes, they can cause weight loss. And they clearly have a renoprotective effect, which I'm going to discuss in a little bit. But in EMPA-REG, I was involved on the Endpoint committee because the FDA was requiring safety studies of any new diabetes drug. And so I wasn't there because I was a clinical trialist as a cardiologist. I was there because they needed cardiologists to judge the safety of the drug. And in fact, what we saw was this profound, unexpected benefit on heart failure events and cardiovascular outcomes trials. The EMPA-REG study was the first of numerous ones. And so we now know these drugs are really powerfully important for primary prevention, and that's the talk I'd love to come back and do some other time, but also for treatment of patients with symptomatic established reduced EF and preserved EF heart failure. So the first trial to land was John McMurray's DAPA-HF trial. DAPA-HF was a study of low to intermediate risk individuals with heart failure and reduced ejection fraction, EF of 40 or less, relatively low baseline NT-proBNP. So these were in a somewhat younger population. These were people with, early to mid-course reduced EF heart failure. The last slide said it, but if you give an SGLT2 inhibitor to someone without diabetes, they don't get hypoglycemic because the way the drug works is it causes glucoseuria if your circulating glucose level exceeds a certain level, around 200 or so. So if you give it to a non-diabetic, no problem. If you give it to a diabetic patient who is not taking insulin or a sulfonylurea, similarly, no real problem. You have to watch with the diuretic effects if a person has hyperglycemia. But generally speaking, these drugs are really well tolerated. And in DAPA-HF, as the slide shows, there was a 26% reduction in the primary endpoint of heart failure hospitalization, worsening heart failure, so that was an outpatient intensification endpoint, or cardiovascular death. And in fact, a key secondary of hospitalization for heart failure was reduced, as was cardiovascular death. Important message, and I'll tell you why with the next slide. We did the Emperor Reduced study. So I was involved with Emperor Reduced, wherein we were able to show, again, about a 25% reduction. Seems pretty consistent, right? 25% reduction in the primary endpoint of cardiovascular death and heart failure hospitalization. Our key secondary endpoint was first and recurrent heart failure hospitalization, where you see that it not only reduces one event, but multiple events, which is, I think, an important message in heart failure. Emperor Reduced was a higher risk population. These were patients that were older with a higher NT-proBNP. We put in the inclusion criteria an NT-proBNP criterion requiring higher values for people with ejection fractions closer to 40%, with the idea that we really wanted to enrich for risk. So what did this do? Well, it really amplified the impact on heart failure hospitalization. But interestingly, in Emperor, we were not able to show an impact on cardiovascular death the way it was in DAPA-HF. This does not mean the drugs differ. What it means is the patients differ. Remember that slide I showed in the very beginning that Mihai Georgiadi showed, that as you get down further and further on the downhill course, the amount of damage and myocardial remodeling is worsening? The idea is to catch patients earlier in their course, earlier in the journey of heart failure, so that they don't get to that advanced stage, wherein we had many more in the Emperor Reduced trial. So does it reduce events? Absolutely. Does it reduce hospitalization and congestive endpoints? Absolutely. But catching people at an earlier stage of heart failure is critically important. I already said these drugs are not treating diabetes and heart failure necessarily, and indeed the benefits, here's DAPA-HF, just showing that if you did or didn't have diabetes, it didn't matter. The reductions were similar. And the value of sacubitril valsartan and Sglt2 inhibitors is additive. So when you look at the combined use, the benefits are even greater than using either sacubitril valsartan or an Sglt2 inhibitor, which makes perfect sense because they have completely different mechanisms of action. Of course, the mechanism of action of Sglt2 inhibitors remains very much in ambiguity. We know that the drugs have short-term diuretic and natriuretic effects. We know that they have benefits, as I've already said, on a number of, I think, important factors that will reduce risk in chronic heart failure. They have metabolic effects on the myocardium, as well as inducing pathways associated with myocardial resistance to injury, HIF-1 alpha based pathways and others. So there's a number of different potential mechanisms, but as I've repeatedly said, there are more review articles on the benefits of Sglt2 inhibitors and possible mechanisms than there are actually translational studies. And so we really, I think, need to figure this one out. I mean, we do know that Sglt2 inhibitors cause an early diuretic and natriuretic effect and reduction in filling pressures without activating the renin-angiotensin-aldosterone system. This is a really interesting phenomenon. Basically, what happens is when you block the sodium glucose cotransporter, you deliver more sodium to the distal tubule and you pee it out. By doing so, you stimulate the macula densa to change afferent arteriolar tone through something called tubulo-glomerular feedback. So early on, you get this dumping of sodium and you definitely see a reduction in filling pressures. But the thing is that wears off in about 4 weeks as the afferent arteriolar tone goes up, intraglomerular pressure goes down. So there's more to it than just a smart diuretic effect. But that change in afferent arteriolar tone, which is a preload reducing phenomenon in the glomerulus, leads to this wonderful effect. This is the eGFR slope in Emperor Reduced. So in black is the course of the estimated GFR in placebo-treated patients. Early on, from an increase in afferent arteriolar tone, eGFR drops. But then over time, the GFR flattens out through, as I tell my patients, the effects of the drug to protect your kidneys. It's unloading the glomerulus. And in doing so, the double phenomenon of an early worsening of GFR with a longer term improvement is a critically important finding that is strongly associated with benefit in reduced EF heart failure. So very important finding, worth discussing later when we talk about implementation. Now, I couldn't help myself. I'm a biomarker guy. I had to do it. We looked at NT-proBNP in the Emperor program, and here are the results from Emperor reduced. Now, compared to the 30% reduction within 2 weeks and the 37% reduction by 1 year in sacubitril valsartan treated patients, the reduction associated with treatment with empagliflozin is smaller. So empagliflozin does cause a reduction in NT-proBNP, but it is a smaller and more delayed phenomenon. So what might this mean? Well, once again, I remind you, in a non-congested patient population, serial changes, serial reductions in NT-proBNP are strongly associated with reverse remodeling. And indeed, the investigators from Mount Sinai, as well as Glasgow, were able to show significant impacts on remodeling parameters with reductions in volumes, improvement in EF, reductions in LV mass, as well as some changes in functional capacity and symptoms. So critically important, sort of last piece of the puzzle in a way, in terms of understanding the benefits of this drug in patients with heart failure. So that brings us to the marketing strategy that we've tried to follow in the heart failure world, which is talking about the 4 pillars of GDMT for heart failure with reduced ejection fraction. 4 pills, 5 pathways, numerous benefits: reverse remodeling, improved quality of life, heart failure hospitalization reduction, fewer deaths. We're pulling people up in that curve that I opened up with. And indeed, when you look at the potential benefits, these are modeling data from the Brigham and Women's Hospital. The what if you optimally treated a 55-year-old, that's my age, 55-year-old with heart failure with 4-drug contemporary therapy versus a combination we still see all the time, an ACE and a beta blocker. 8 years of event-free survival added to this patient's life, in this modeling study. So really, at this stage, the imperative is to stop debating and really thinking about how to optimally treat these patients. Now, fortunately, the talk would end, or at this stage, but we have something new to talk about, and I wanted to close with some of the more exciting data, which is that previously we had this elephant in the room, which is, I'd say, thank you very much, I'm glad to have come and spoken today, and people would at the end say, well, what about preserved EF heart failure? And yes, preserved EF heart failure is 50% of the patients we see. And the problem is that, the clinical trial world has been marked by just one, train wreck after another of clinical trials that have failed to show an impact on preserved EF heart failure. And part of the challenge is that we have great preclinical studies with reduced EF identifying all these final common pathways that we can target. I hasten to add, however, that all of the therapies we use in heart failure with reduced EF were developed for other disease states. But still, somebody smart enough was able to realize that they could be used in reduced EF heart failure. But the problem is, in preserved EF, there's just a jillion different reasons why patients get heart failure with a preserved ejection fraction. Some are in the heart muscle, some are outside of the heart muscle. And so understanding how to individualize therapy to address these issues is the way to roll in preserved EF heart failure. And that's how come, and one reason why many of us believe that spironolactone, a drug, a mineralocorticoid receptor antagonist, very modest diuretic effect, but really more of a biological effect on collagen cross-linking in the myocardium to reduce myocardial stiffness, among other reasons, may still have yet a role in patients with heart failure with preserved ejection fraction. So who might those patients be? Well, first, in the TopCat study, which was an overall neutral trial, the investigators saw this really interesting inverted U shape between natriuretic peptide values and benefit of spironolactone. And basically the take home is if you have a modest elevation in BNP or NT-proBNP, you actually had some clear benefit, congestive phenotype. Not too much elevation. If you had a very high NT-proBNP, you actually didn't benefit. So modest RAS activation, modest congestion, seemingly clear benefit. In addition, no surprise, once the ejection fraction crossed the Rubicon and got to a range that was where the RAS was activated, no surprise, spironolactone had benefit. Indeed, in TopCat, they enrolled all the way down to an EF of 45. So clear opportunity to treat patients with mildly reduced EF. And indeed, men and women have very different responses to spironolactone, largely, I think, on the benefit of the way we assess ejection fraction in men versus women, just by the fact that our volumes differ and our normal reference ranges probably differ as well on the basis of sex. So we can appreciate that women seem to have benefit across nearly the whole range of ejection fraction, whereas men, it really was once you got to this mildly reduced population. Very similar results were seen in the Paragon trial, which was sacubitril/valsartan. So this was a trial of sacubitril/valsartan versus valsartan. So this was not placebo controlled. The trial barely missed its primary endpoint. And people make a lot of hay about this. What people should be talking about more is the fact that even if it was positive, the risk reduction was only 13%, right? So it's not a huge impact on outcome. So can we make that better, if you will? Well, yes, clearly, once again, once your ejection fraction is a bit below what is considered normal, the RAS is activated, and a treatment with a RAS inhibitor like sacubitril/valsartan was clearly associated with benefit. And once again, we see that in men and women, there's this differential benefit where women had benefit all the way up to an EF at or around 65%. So, the US Food and Drug Administration and many of us actually feel that the drug actually works, both spironolactone and sacubitril/valsartan work in people whose RAS is activated. Where that normal EF is, I'd love to maybe talk about, but it's, when you cross a certain normative level, and the EF of 55% that the American Society of Echo has talked about for years now may very well be that signpost along the road. One last subgroup of interest is the fact that in Paragon, those individuals who were enrolled after a recent heart failure hospitalization also had clear benefit, really implying the congestive phenotype, once again, the RAS activated phenotype is one way to recognize these patients. So all of that is subgroup analyses and me sort of massaging the data. Can we just please have a study that we can look at and say, okay, this works? And that was the Emperor Preserved study, the last trial I'm going to show you. We recently reported the Emperor Preserved results in the New England Journal of Medicine right around the ESC, where we were able to show a 21% reduction in CV death or heart failure hospitalization. Notice a very, very important point, which is that the placebo-controlled arm had a very low event rate overall. So there was no impact on cardiovascular death. This was driven largely by heart failure hospitalization, which is unsurprising when HFpEF patients typically have a higher non-CV death rate than patients with REF, and the background risk is relatively low. Nonetheless, a 21% relative risk reduction, is nothing to sneeze at. And indeed, just like as I mentioned with sacubitril/valsartan, these are data that were just published actually. The benefit of the drug was actually seen. So this is a neat way of showing hazard ratio on the y-axis. The benefit of sacubitril/valsartan was seen immediately. Not sacubitril/valsartan, I'm sorry, empagliflozin was seen immediately and achieved statistical significance by 3 weeks after randomization. So that's a really important observation. It really, once again, implies, delaying initiation of therapy exposes patients to risk. Now, subgroup analyses. Were there any subgroups that did or did not benefit? Again, we come back to this weirdness about heterogeneity based on, for example, baseline natriuretic peptide values. If your natriuretic peptides were a little bit elevated, you got some benefit, for example, from spironolactone. The answer is, and these data have not been published yet, there is none of the weirdness that we saw with NT-proBNP in the Emperor Preserve trial. Basically, across all NT-proBNP strata, the drug exerted similar relative benefits. So there was no interaction by baseline NT-proBNP, implying, therefore, that a lot of the previous findings with other therapies in HFpEF are interesting and important, but do not extend to preserve DF treatment with empagliflozin. Profound impact on heart failure hospitalization. And this is, I think, probably the last and most important slide, which is essentially unlike spironolactone and sacubitril/valsartan across the entire wide range of EFs in the entire Emperor program, we saw benefit of empagliflozin. So from a practicality perspective, you all know, I would hope that understanding these drugs and the nuances is really important. What we do in our Gdmt clinic is we'll often either switch patients to an ARB if we know we're going to eventually change them to sacubitril/valsartan, but we stop the ACE inhibitor, we cut their loop diuretic when we initiate sacubitril/valsartan, and we push the dose every week, if not sooner. We always follow up with labs for monitoring NT-proBNP, potassium, and creatinine, and very similar type recommendations for MRAs and Sglt2 inhibitors. You know, understanding how to use these drugs really crosses all boundaries in all specialties, and cardiologists and CV team members cannot sit on the sidelines anymore. And that speaks to the last point I want to make, which is, you know, it was easy when it was DIG, diuretic, and an ACE inhibitor. But now there are all sorts of choices that we have to think about. And there are drugs that have just come out, and everything seems to have a target dose rather than a biological target that we can sort of measure and move on from. And that leads to the CHAMP-HF experience, which is all of those gaps that exist in heart failure care. And I come back to the fact that, you know, as a trustee of the college, American College of Cardiology, I'm very grateful for the focus that the college has taken on optimizing care for patients in need, including those with heart failure. We published the expert consensus decision pathway document, which I won't go into other than to say it's worth looking at, because what it looks at is not focusing on why you should do something, which is what this whole talk has been about, but more about how to do it, right? Which is something that is so lacking in guidelines. You know, this consensus document focuses on important subjects, really notably including how to add, switch, intensify therapies for reduced EF heart failure. And we also talk about preserved EF heart failure, where we're now coming forward with a consensus document imminently, because unlike in 2017 and 2021, when we largely focused on therapies that we knew worked in reduced EF, we now have therapies in preserved EF that we can talk about. And my general recommendations are, you know, do not delay in both reduced and preserved EF, and to individualize care. All folks should get an Sglt2 inhibitor, short of those individuals with, say, hypertrophic cardiomyopathy or cardiac amyloid. Individuals should probably also get MRA, particularly women, particularly for those with activation of the renin-angiotensin-aldosterone system. And sacubitril/valsartan in a very similar way should be used in individuals with heart failure, again, with a RAS-activated phenotype. The ways that you can do this, it's up to your own individual institution. We recommend both starting as an inpatient whenever possible, but if you are unable to start these therapies as an inpatient, very, very important model that we've now brought forward at the Massachusetts General Hospital is the Gdmt Clinic. This is not for the heart failure section. This is for general cardiologists and for internists. And the goals of the Gdmt Clinic are to institute and titrate therapies, improve patient care, get these folks on the treatment that they should be getting within 4 weeks as a goal, and then releasing them back to their managing physician. It's very, very important to treat and release these folks back to the doctors who know them so well. And I'm going to wrap up at this point by saying, you know, it's been a really interesting journey, sort of marrying the clinical and translational features of, how we think about heart failure. And, you know, I hoped that we could define the problem and talk about the optimal GDMT for these patients. For reduced EF, we have the armamentarium, initiate it early and often. HFpEF, we now have an expanding understanding of the armamentarium with Sglt2 inhibitors for all, MRAs and ARNI for many. And lastly, how to close those gaps in heart failure, really thinking about from an institutional perspective, how you may be able to, in your heart function clinics, as well as for your general cardiologists and primary care doctors, close those gaps. So I will stop here. I'd like to thank you very much for the opportunity to return virtually, and next time, hopefully in person. And I look forward to the question and answer session. Thank you so much.
Yeah, great. Thank you so much, Jim. This is just an unbelievable, masterful presentation. So it really shows that not only Jim is a master clinician, a translational researcher, but a master teacher as well, to really bring forward the importance of GDMT early usage, new opportunities, but at the same time, the potential insight as to why these things work the way they are. This is just fantastic. And so maybe there are a number of questions. Maybe Rob, you want to start with a question and we can alternate?
Sure. There's a question here from Dr. Lisa Milnichuk. First, thanking you for your outstanding talk. I'm sure you know Lisa. I wonder if you can elaborate on the role of using biomarkers to guide therapy titration in this new era, particularly in the decisions of how to start and titrate for foundational therapies, and whether they should be used to titrate more personalized therapies, such as in Victoria trial, and those with NT-proBNP greater than 8,000. Actually, certainly the first part was similar to a question I was about to ask as well.
Yeah, thank you. Outstanding question from Dr. Milnichuk, not surprising. So thank you first on your compliment. So look, as a biomarker person, I believe that markers have a lot to inform about optimal care. As a clinician and as a trialist, I would argue that, there's clear benefit across the wide range of natriuretic peptide values, for example, of each of the therapies we've talked about, excepting vericiguat, which I'll talk about in a second. So what that means is you're not going to use markers to decide who does not get therapy with the standard 4-drug approach. On the other hand, monitoring response to therapy is critically important in my view, because it informs the impact of the drug on the various drugs on heart muscle integrity, on remodeling status. So what we do is we measure NT-proBNP at every visit in our patients as we're titrating, and then longitudinally in follow-up. Why do we do it? 2 reasons. First reason is to monitor response. For those people with a really dramatic reduction in NT-proBNP, their EF is getting better. I mean, it's just almost a guarantee in most cases. Why does that matter? Those are patients that you're not going to send for a right heart cath, a cardiopulmonary exercise test, a cardiac MRI. You're going to manage them conventionally and may not even echo them with any great frequency as long as they're symptomatically stable and their NT-proBNP is low. For those with non-response or increase, that raises the likelihood that despite GDMT, these patients will need referral for advanced heart failure evaluation, or that they have something that isn't quite responsive to GDMT. Amyloidosis as a prime example of a diagnosis that we now see is so much more common than we realized previously, and is manifested. The hallmark of amyloid is unexpectedly elevated natriuretic peptide and troponin values, and it's due to the direct injury of cardiomyocytes by, for example, transthyretin, which causes elevations that when you diurese patients, you can get them to a wedge pressure of 3 and their NT-pro will still be 5,000. So again, very important not to fall for the trap of assuming that NT-proBNP equals filling pressures in these patients. So vericiguat, I didn't mention it, but you're absolutely right. And of course, this was a trial that was done by many Canadians. Paul Armstrong was one of the principal investigators, and so what can we say about this drug? Really interesting. So it's a cyclic GMP stimulator. That in the Victoria trial of recently decompensated patients was associated with a 10% relative risk reduction, but because these patients were so high risk, the absolute risk reduction was actually quite robust. The problem in Victoria was that there was a recognition that people with an NT-proBNP above 8,000, it was the upper quartile was around 5,000, but the threshold was actually around 8,000, where that treatment was associated with greater risk in these people. There was in fact an interaction term in outcomes such that people with an NT-proBNP above 8,000 had a worse effect from the drug rather than a reduction in events. What this means ultimately, it remains to be seen. They're doing the Victor trial now as part to try to address this issue. But the conventional thinking is, starting the drug in an eligible patient for someone with a lower NT-proBNP is fine. Monitoring, and if they cross the Rubicon and cross over 8,000, probably stopping the drug until you recompensate them would be a logical approach. What do you do with somebody who starts at 8,000 and then drops? Like say, somebody coming out of the hospital, probably start it, but watch them closely is I think what you should do.
Wow, so fantastic wisdom right there. And so maybe just one more question, and this has to do with the nice data you presented in terms of ARNI, allowing the opportunity to reverse remodeling. And in fact, we see some patients now with these agents can actually normalize their EF. And then the follow-up question is actually, in that setting, do you reduce the medications? What do you do with the patient who actually successfully reverse remodeled?
Yeah, if I can just add to that, to also maybe comment on the patients with the renal dysfunction.
Yeah, absolutely. I was actually, Rob, I was going to hit both of the remaining questions with the same answer, in fact. So thank you for that. One, there are very, very, very few circumstances where I will back off, reduce, or stop therapies in patients with previously reduced heart failure. Why? Heart failure with improved or recovered ejection fraction is also now considered in the universal definition of heart failure. And what we talk about is that these people are exposed to the return of cardiac remodeling, which is a reduction in EF over time. The TREAD-HF trial looked at non-ischemic patients randomized to discontinuation or continuation of GDMT after recovery. 50% of the individuals had a return of a drop in their EF when the drugs were stopped. So we never stop the drugs in most patients. Who do we stop them in? People with tachycardia-mediated cardiomyopathies that have recovered and sinus rhythm has been held. People with stress cardiomyopathy whose EFs have recovered. Now, what about worsening kidney function? So Yas Moayedi asked, what's my Sglt2 Gfr cutoff? In the Emperor study, we randomized down to a GFR of 20 to 25. But if the GFR dropped below that, we didn't stop the drug. So and the drug has been approved by FDA with a GFR minimum of 20. So I'll start it all the way down at that level, and I will ride the GFR all the way down if it worsens. I'll keep it on because I actually firmly believe much of the benefits are not renal, are effects on the heart muscle, while of course there are benefits in the kidneys. Very important point, however. I pointed it out in the eGFR slope slide. When you start an SGLT2 inhibitor, you should expect a drop in GFR, particularly in people with worse kidney function to start with. This is not AKI, it's not tubular injury, it's not going to cause worsening problems. So when you start an SGLT2 inhibitor, it is critical to message this to your colleagues so that your patient on 4 drugs doesn't return to you on 3 drugs because the SGLT2 was stopped because the creatinine rose a little bit and they misinterpreted that finding.
Thank you. I think, Peter, there's one question in the chat, I think from Gordon. I don't know if Gordon can unmute. There he is.
Hey, Gord, how are you?
We can finish with Gordon's question.
Yeah, Gordon, go ahead. Yeah, so thanks for joining.
I didn't intend to ask a question, but since you asked me, I would ask now. And it's the same old question since day one, Jim. Is how do you handle NT-proBNP level in patients who have a kidney dysfunction? I asked this question since day one.
You have, ever since we started testing it back in the early 2000s. It's a challenge. it's more, I feel it's more of a challenge in the inpatient setting, Gord. In those patients, where you've got all sorts of disarray, acute kidney injury, acute changes in GFR related to congestion, it can be challenging to interpret natriuretic peptide values. But in the acute setting, the delta NT-proBNP after treatment is still very, very prognostic, even in those with CKD or even AKI. In the outpatient setting, actually, we've got a whole series of patients with creatinines of 2.5 to 3, where we've been able to get the NT-proBNP well below 1,000 in many of them. Importantly, I remind the audience, the myocardium releases NT-proBNP for so many different reasons besides congestion. And in worsening kidney function, the circulating milieu is quite toxic to the myocardium as you approach stage 4 or 5 CKD. So some of the release of natriuretic peptide is actually a response to this, sort of unwell sort of environment that's associated with loss of renal filtration, et cetera. But then also, of course, you have to worry about congestion in these patients. So, all of this, needs to be brought into consideration when we treat these patients.
Thank you.
Thanks, Gordon.
Yeah. Thanks so much. Yeah, so I think you view the hour and certainly enthusiasm, we can see really, sort of the impact of Dr. Januzzi's talk is really fantastic that he shared his wisdom, but also, the clinical pearls, right? We really now have fantastic GDMT, and that both of us have ref, and that we can really be bold and be early, and conquer this new frontier and really make a difference for the patient. So thank you so much, Jim. Really look forward to, I know that you're sharing some of your wisdom with our trainees as well. Really appreciate that. And also roundtable for those who want to join in on the discussion and follow some of these further as well. So thank you very much for everyone to follow, to join us on this grand round. And so look forward to further discussions.
Thanks
Really
very much.
fascinating, fantastic, and enlightening talk, Jim. I really appreciate you coming. Thanks so much.
Thank you.